Hello everyone. Today let's learn about another important topic named as femur shaft fracture. So let's first learn about femur. Femur is the largest bone of the body. It is a load bearing bone of the body. Fracture of shaft of femur is associated with prolonged morbidity and extensive disability unless treatment is appropriate. So one of the cardinal feature of femur shaft is its anterior bow. Okay, so now let's learn about the muscles which are present in the thigh. So they are divided into three compartments: anterior compartment, medial compartment and posterior compartment. The anterior compartment includes quadriceps femoris, it includes iliopsoas, also sartorius. Along with this, it also consists femoral artery, it consists of femoral vein and nerve. Next comes is the medial compartment. The medial compartment consists of adductor group of muscles. So they are adductor longus, adductor brevis, adductor magnus. Along with this also consists of gracilis and pectineus. In this compartment also consists of obturator artery, vein and nerve. Along with this you can also see that profunda or femoral artery is also present. In the posterior compartment it contains three muscles: biceps femoris. It also consists of semitendinosus and semimembranosus. So these are the three muscles which are present in the posterior compartment. Along with this, in the posterior compartment you can see the sciatic nerve also comes in the posterior compartment. Now let's learn about the mode of injury. So it most commonly occurs because of high energy trauma. Pathoanatomy. Fracture can occur anywhere in the upper 1/3 or middle 1/3 or lower 1/3. It can be either transverse type of fracture, spiral, oblique or comminuted depending upon the fracturing force. Next comes is the displacements. So for displacements, this diagram is very important. In the displacements, this is the proximal fragment, this is the distal fragment fracture. Okay, so this proximal fragment is usually flexed, abducted and externally rotated because abductors are attached to GT. And iliopsoas is a chief flexor, it is attached to LT. So what happens is the abductors, as they are attached to GT, they are helpful for abduction and external rotation. So that is the reason the proximal fragment will be abducted and externally rotated. Next comes, this is the distal fragment. As adductors are attached to the distal fragment is adducted. The unsupported fracture end of the distal fragment sags because of the gravity. Next comes is the clinical features. So in clinical features you can observe that the patient comes to you with complaints of pain, swelling, deformity and abnormal mobility. Next comes is radiographs. So what all radiographs you have to take when a patient comes to you with these clinical features are X-ray of whole femur and X-ray pelvis with both hips. So this is an radiograph of whole femur showing there is fracture present in the middle 1/3 shaft. So next now learn about the classification. So in Winquist and Hansen classification, it is divided into 4 types. In type 0 there will be no comminution. In type 1 there is insignificant amount of comminution. In type 2 greater than 50% of the cortex will be contact. In type 3 less than 50% of cortical contact is present, and in type 4 it is segmental fracture with no contact between proximal and distal fragments. So here this is type 0. It will have significant amount of comminution. You can see that there is no comminution present here. This is type 1 with insignificant amount of comminution. In type 2 more than 50% of the cortex will be contact. In type 3 less than 50% of the cortex will be contact. In type 4 what happens is the fracture is segmental, and here you will have no contact between proximal as well as the distal fragments. Okay, now let's learn about the treatment options. So in the treatment options you can have 2 treatment options. They are conservative and operative. So in conservative, skin traction is usually preferred in children, skeletal traction is preferred in adults. So skin traction is preferred in children, skeletal traction is preferred in adults. In adults, Stemen pin you will pass it through upper end of the tibia and weight is applied through it. Hip spica is also another conservative management. So what happens here is, in hip spica, plaster cast is incorporated part of the trunk and the limb. So here you will apply a plaster cast starting from trunk. Either you will apply it to the affected limb, or along with the affected limb, even half of the non-affected limb is also applied. So it may be either a single spica involving only affected limb, or 1.5 spica. Next comes is operative methods. Operative methods include external fixation done in massively contaminated fracture, or fracture requiring rapid stabilization for vascular repair. Temporary external fixation of femur shaft can be used in unstable, severely injured polytrauma patients. So when a polytrauma patient comes to you, for immediate fixation, you can use temporary, as a temporary source, you can use this external fixation method. After wound coverage for 2 weeks, then you'll convert it into definitive management. So the definitive management includes either intramedullary nailing or plating. Intramedullary nailing is the most commonly employed method. So this may decrease the chance of infection if you do it in this way. Okay, so basically you have to remember one thing is, in polytrauma patients, temporary external fixation can be done. After adequate coverage for 2 weeks, then you'll convert it into definitive fixation. Definitive fixation includes either intramedullary nailing or plating. Now let's learn about plating. Plating is used when medullary canal is too wide for nail to have good hold. It can also be used as a most accurate reduction for comminuted fragments of the femur shaft. It can be obtained by interfragmentary compression and plate and screw fixation. Minimum 16 cortex hold, at least 8 screws have to be kept. That is desirable. This treatment allows early motion and good function, but risk of infection is 2 to 5%. Failure of fixation is 6 to 10%. Delayed union is seen in 19%. Commonly used plates are AO heavy duty plates, or also condylar blade plates also can be used. Next comes is intramedullary nailing. Can be either done through 2 methods, either antegrade or retrograde. Usually most commonly preferred method is antegrade method. Okay, a retrograde method of nailing is used in morbidly obese patients in pregnancy, ipsilateral femoral neck and shaft fracture, ipsilateral femoral and tibial fractures. Okay, so for antegrade nailing, the entry point is usually the greater trochanter. Nail is introduced into the intramedullary canal from greater trochanter after fracture being reduced without opening. So if the once the fracture is reduced, when you introduce an intramedullary nail without opening it, this is known as closed nailing. Recent addition to closed nailing is interlock nailing. So in interlock nailing, here you can observe that 2 horizontal screws are being applied. This is applied in order to keep the intramedullary nail in its position. Now next comes is in children. In children, treatment usually up from birth to 2 years, we commonly use something known as gallows traction. In gallows traction, leg of the child are tied to the overhead beam. So here you can see that legs of the child are tied to overhead beam. And even the hips are slightly raised from the bed. So here the body weight acts as counter traction. Okay. So here the body weight acts as counter traction and fracture is reduced. From 2 to 16 years, we use either hip spica or internally fix the fracture in older children. If more than 10 years, usually we go for TENS. That is nothing but titanium elastic nail system. Nails are used. Next comes is complications. Complications of femoral shaft fractures are divided into early complications and late complications. Early complications include shock, fat embolism. So a patient can have very severe blood loss. Usually 1000 to 1500 ml of blood loss can happen intraoperatively. So regular heart rate and BP monitoring has to be done in post-operative period. So fat embolism is also one of the another important cause. Injury to femoral artery, injury to sciatic nerve and infection. Late complications can be delayed non-union or malunion. This is all about femur shaft fractures. I hope you liked the video. Enjoy, take care, bye-bye. If you like the video, please do like, share and subscribe. Thank you.